We'll move on to our second presentation before the break, and most of you know Doug quite well. He's now. I never say the short form of this anymore. It's the Institute for Clinical Evaluative Sciences, just in case people misconstrue. And you'll get that if you just write it in big letters. He's currently the CV program lead at Toronto General Research Institute. He's a cardiologist at the Peter Munk Cardiac Center. He's a former winner of the Robert E. Beamish Award, which is a research achievement award at the CCS every year. And he focuses on, shall we say, big data. And we'll talk today about modeling heart failure outcomes right from the emergency room. And you might ask yourself at the end of this talk, is all heart failure ischemic? Doug.
Great. Thank you very much, Dr. Howlett, for this that wonderful introduction. I think Dr. Hernandez's talk was an excellent lead-in to what I'm going to talk about, specifically the comment about providing the right care and the right time and the right outcomes. But we'll be focusing on the acute setting in the emergency room. These are the objectives. We'll be looking at trying to kind of convey to you what happens in the acute setting in heart failure and the decision-making challenges that clinicians face, and then to discuss how the emergency department might be an important focal point for helping us to reduce the problem of readmissions that was alluded to earlier. And then to look at this issue of transitions of care and the issue of readmissions. So I'd like to start with a case of a patient that we saw in the emergency department. This is a woman who presented with new onset heart failure. She had complained of dyspnea for a couple of weeks, shortness of breath, and was diagnosed as having a viral illness at the onset, and then subsequently diagnosed with pneumonia, didn't improve with antibiotics. Very common story in heart failure in heart failure presentations. And then presented with a history of she had a hypertension and diabetes, but no other prior cardiac history. Not on any medications other than an ACE inhibitor and on no diuretic. In terms of her presentation, her vital signs, she had a mild tachycardia, mildly elevated respiratory rate, and hepatojugular reflux was positive. She had some bilateral crackles and a pansystolic murmur. And in terms of labs, not too impressive other than a mildly elevated troponin, just greater than the upper limit of normal, certainly not in the MI range, not in the range that would indicate that the patient has myocardial infarction. And so she started on Lasix in the emergency department, diuresed very well, and improved dramatically. And so the question arose, what should we do with this patient? Should we admit the patient or discharge the patient home? This is a common question that arises in the clinical world. The decision was made to admit her to hospital. She had an echo performed, which showed that she had systolic heart failure. LV ejection fraction was 20%. Her ventricle was dilated, and she also had moderate to severe MR. She subsequently went on to testing to look for the underlying reason for her heart failure, and this showed significant ischemia in the heart, showing that on the stress images on the top and the rest images on the bottom, in 3 different orthogonal planes, showing a reversible perfusion defect in the inferior wall, in the anterolateral wall, in the anteroapical wall, and transient ischemic dilatation. So she went on to coronary angiography. I'm just going to ask and this is the right coronary that was the right coronary, and this is the left coronary, showing severe obstructive disease in both the left and right coronary circulation. She subsequently underwent bypass surgery, and 6 months after had remarkable improvement in her LV function, near normal LV function, her heart size actually decreased to normal, and her heart failure symptoms resolved. And so if you harken back to that original question, what would have happened if we discharged that patient, and how a decision made in the emergency department could have had a significant impact on this patient. So as we've heard before, heart failure is a major problem in healthcare. It is a leading cause of hospitalizations. The worldwide costs are estimated to be over $108 billion. There is this graph shows the nations where the costs per capita are particularly high, and you can see that a lot of the developed nations have the highest costs. That's not too surprising. And as the developing nations increase in prosperity, there will likely be more coronary disease and heart failure to follow. In North America, there's more than 1 million ED visits annually, and the readmissions, once a patient is discharged from hospital, there is a major issue in healthcare that we're grappling with of readmissions. 25 to 35% of heart failure patients are readmitted to hospital after initially being discharged. And in fact, it is one of the leading reasons for readmission in North America. When we look at readmissions, what we see is that it is a complex problem. This graph shows what happens to a heart failure patient after they're initially discharged from hospital from their first heart failure hospitalization. And what we did in this study was divide the patient's lifetime into tenths, into deciles, and look to see where do readmissions tend to occur. And we see that a lot of the readmissions occur in that first decile there. There's a definite spike up there. Within that corresponds to about 60 days from the time of initial hospital discharge. And you see that there's another spike near the end of life, right at the very end, that 10th and last decile of life. And the other observation is that readmissions occur for heart failure, but they also occur for other cardiovascular causes, and they also occur for non-cardiovascular causes. And so the readmissions can occur for a varying number of different reasons. Now, why is it important? Well, it's also important to the patient because, as shown in this study here by Sadaguchi and Lynn Warner-Stevenson, every time a patient gets hospitalized, every time a patient with heart failure decompensates to the point they require heart failure hospitalization, that indicates that they're getting sicker. And that translates into a greater risk that they will die. And this graph shows that after the first heart failure admission shown in blue, that is the cumulative time to death, but the risk is increased after the second heart failure hospitalization shown in red, and then progressively goes up every time a heart failure patient is hospitalized. Now that doesn't mean that we're killing patients in the hospital. We interpret it as saying that when patients are sick to the point that they need to come into hospital, that's a real warning sign that they're quite sick and they're at great risk of dying in the future. And so a real area of important focus. Now, as Dr. Hernandez is an outcome researcher, and I am as well, and as we look to try to tackle these types of problems, one of the first things that we do is to try to understand variations. And there was a mention of variations earlier in the previous talk. And when we try to understand variations, there are multiple factors that can contribute to variations. One of the big contributions to variations is the patient. Patients come in all different types of presentations and have different characteristics. And so the patient themselves, the variation in the patient can contribute to the outcomes that we see. In order to help us to try to understand from a health system perspective, what is it that we're doing right and what is it that's helping to improve outcomes, we really need to know about those patient-related factors first, so we can take those out of the equation, and then we can analyze the process-related factors that contribute to variability. And so when we look at patients who are hospitalized, who come into the hospital, one of the major challenges has been to try to predict who gets readmitted for heart failure after an index heart failure discharge. It is a challenge to try to predict, using mathematical models, who's going to be more likely to be admitted. And so you could imagine that if you, at the time you were about to discharge a patient, could tell that a patient was a high risk compared to another patient who's at low risk of being readmitted, well, you might be able to alter what you would do for that high-risk patient and how you would treat them and manage them compared to the low-risk patient. And so therefore the great effort spent to try to understand, can we identify higher-risk patients? There's a lot of variation in these mathematical models that have been published, as you can see here, ranging from less complex models shown on the left, really complex models shown on the right, and a really, really complex model shown here. One of the challenges has been that we haven't really been able to come to a solution here. And these are just a summary of how well these different models predict outcomes using a C statistic, which is a statistical measure of how well a model predicts a C of a value of 1 being perfect discrimination, and the C value of 0.5 being not that great. And as you can see here, when you look at these models, the C statistic has been about 0.6, so modest ability to predict outcomes of death or readmission. In fact, the two best models probably of the 5 are the Amarsingham model, which is a single center study, and so can it replicate in a different hospital setting or a different jurisdiction, and the Ascend heart failure readmission model, which is a model for death or heart failure readmission. Those are the two best ones. But one of the challenges may be due to the fact that death and readmission have been perhaps combined together. And so I use this as an illustration of how we, as researchers, have kind of tended to lump the two outcomes together, death or readmission. They're both bad outcomes, and so it makes sense to lump them together. But does it make sense to lump them together? I'm showing you this data that was published by Krumholtz and the Yale group, showing just a simple scatter plot of the rate of mortality on the x-axis and the rate of readmission on the y-axis. And each of these dots here is a hospital. They studied over 4,700 hospitals. Firstly, what one observes is that it's quite a globular pattern, but in fact, there is when you look at the statistically to see if there's a correlation, there is in fact a correlation. The Pearson correlation coefficient was minus 0.17, meaning that, the curve is shown in the blue, the best fit curve is shown in the blue, meaning that as mortality increases, readmission rates decrease. And so, that means that some hospitals where the patients die, their readmission rates are lower. You see two different areas in this graph. The first is the white region where mortality and readmission are concordant. So in the left lower quadrant, you see, I don't know if this, I don't know laser, there's a laser pointer here. So in this lower quadrant here, and over here, this is a region where there's low mortality and low readmission. This is a region where there's high mortality and high readmission. And so these two outcomes are concordant. But you can see from the yellow regions here that this is a region with high mortality but low readmission. And this is a region with low mortality but high readmission. So is it worse to die or is it worse to be readmitted? This is a challenge that this is a challenge that that's quite difficult to and what we're kind of realizing now. That's something that we grapple with in terms of trying to understand this issue. Now, this is another example of the illustration of the challenge of trying to understand readmissions and what happens in the hospital, what happens when the patient leaves the hospital. A biomarker that's commonly used in heart failure called brain natriuretic peptide was studied in this study. It's one of the better studies that have been published looking at incorporating BNP into trying to predict whether a patient will be readmitted. On the model predictors are shown at the bottom of the slide. And in fact, if you focus on the left panel, the model actually, which incorporates both the discharge BNP and the change in BNP from discharge to admission, actually predicts mortality quite well. As you can see here, this is the lowest mortality group in blue. Then the next highest mortality group, this is the next high, and this is the highest mortality group shown in black. And so it stratifies mortality risk quite well. But now what happens when you add readmission into mortality and look at the composite of these endpoints? What you see is that the mortality at 180 days in the highest risk group was about 50%. And by adding readmissions, the event rate went up to by another 20%. Now, in the next lower risk group, you see that the mortality rate, the outcome rate was about 20%. And by adding readmissions, now there's a greater than 40% increase in the endpoint. And so, is this actually a lower risk group than that group? Well, if you're looking at it from the lens of readmissions, probably not. The other challenge has been trying to identify low-risk patients. And so if you take a patient here in the lowest risk group, they have about a 5% mortality rate at 180 days. That's actually quite good. But if you add readmissions to the model, it now goes up to 25% event rate at 180 days. And so is 1 in 4 patients in this lowest risk group are going to be experiencing a bad outcome. So is this group really low risk? These are just some of the challenges that are being faced as we try to grapple with trying to improve outcomes and to try to reduce readmissions. And so as I described earlier, if we could look at a patient, use their data, and then identify who is going to be high or low risk, we could provide perhaps different types of ambulatory strategies that might reduce their readmission rate. In fact, we know some of these ambulatory strategies work quite well. This is data that looking at does it matter what type of physician you see in the ambulatory setting after you're discharged, and in fact, it does. Surprisingly, some patients who are discharged from hospital do not see their primary care physician or a cardiologist after discharge, and by just simply seeing a primary care physician, there's a significant reduction in mortality rate out at about 1 year by about 25%. And then a shared care by a cardiologist plus a primary care physician further reduces that risk. And so this is kind of the optimal care by having a cardiac specialist and primary care physician involved. But again, quite a lot of variability because some patients don't see any of these types of physicians even after the discharge with heart failure. Well, one of the other strategies that we really need to consider is if we're going to try to reduce readmissions, is the emergency department, because patients may bypass this ambulatory care, and they may just simply end up from being discharged from hospital and landing in the emergency department. Dr. Hernandez's data showed that there's actually, it's a quality indicator to try to get patients seen soon after discharge from hospital. In fact, the data would suggest that it's an important indicator because this is, again, data looking at patients who are discharged from hospital, shown here, And it shows what proportion of the patients are readmitted within, at any time point, up to 30 days. In fact, as soon as the patient is discharged from hospital, the very next day, many of the patients end up in hospital. Some patients end up back in hospital on the same day. About 13% of all patients are readmitted within after an initial heart failure discharge within 3 days, and about over 30% are readmitted within 7 days. And so it is extremely difficult to mobilize all of the ambulatory outpatient care that's required within this time frame, and the patient could very likely end up back in the emergency department. And so the emergency department, I would just submit, has to be a part of a strategy to reduce readmission risk. It's also important because you could provide excellent care in the hospital, and a patient could still end up back in the hospital within 30 days. And this study looked at quality indicators, some of the quality indicators that we think are very important in heart failure: use of an ACE inhibitor, evaluation of their LV function, discharge instructions about educating the patient about heart failure, and then smoking cessation. And none of these quality indicators was actually associated with readmission risk. And so the two seem quite different. You can provide excellent care in hospital, but the patient may land up back in the emergency department. Now, the challenge is that there's a lot of variation in the emergency department, and patient. It sounds simple, but there's a lot of variation once a patient ends up in the ED with heart failure. This plot shows the rate of discharge of heart failure patients from the ED, depending on each of these lines as an emergency department in the province of Ontario. And you can see that if you end up at this hospital, the rate of discharge from this hospital is about 70%. Whereas if you end up at this hospital down here, the rate of discharge from the ED at this hospital is about 15%. And there's tremendous variation in between. And so there could be a lot of variability depending simply on which emergency department you end up going to. In fact, there's also a lot of variability. There seems to be variability in decision making as well. This graph is just simply a frequency plot of where each pixel is a patient who presented to a hospital in Ontario during the study time frame. And the green patients are those who were admitted, and the red patients are those who were discharged. In general, you see that the admitted patients tend to be higher risk. The x-axis is basically their statistical risk of the patient, and the y-axis is the number of patients, kind of a simple frequency plot. And as you can see here, so we're doing pretty well in terms of distinguishing roughly who's a sicker patient and who's less sick. But there are some areas of concern. Firstly, if you look at this group over here, you see that some of the discharged patients, the red patients, are actually overlapping quite a bit with the admitted patients. In fact, their risk is actually quite high. And so some high-risk patients are going home. Here you see that some of the lower-risk patients in green overlap with the red patients who are discharged. And so some low-risk patients are being admitted. And we think that this is an issue of safety, and this may be an issue of potentially inefficiency. And when you look at the region here where patients are kind of similar, they have a similar risk, and you actually follow out what happens to them, you see the evidence of perhaps suboptimal post-discharge care and outcomes. The discharged patients here have a higher mortality, in fact, than those who are admitted. And so there's evidence for perhaps problems of safety and inefficiency, and perhaps improvement, the room for improvement in making decisions in the ED for heart failure. We think one of the reasons why, perhaps, and we hypothesize that one of the reasons why this phenomenon may occur is because the doctors in the emergency department who treat heart failure patients may not have the tools to be able to treat heart failure, to be able to distinguish who's sick and who's not. And it's illustrated by the case that we showed was, it can be sometimes difficult to tell who's sick and who's not when you're just faced with a patient at the bedside. And so we have developed one of their many methods. One of the methods that we've developed is the emergency heart failure mortality risk grade. It's a method to stratify risk within 7 days of the heart failure patient presenting to the emergency department. It's a mathematical combination. It's a model that's available that you can go to this website to test as a calculator. And it includes several different factors, which then weighs those mathematically and then provides a single number, a single probability estimate based on that patient's characteristics. Now, I won't dwell too much on the details here, but would like to focus on this one particular aspect of one of the important covariates, and that's troponin. Troponin is often something that we associate in the cardiology world with necrosis of the myocyte and perhaps ischemia. And so that actually led us into a series of studies looking to see, is it important? Is ischemia perhaps important in prognosticating in heart failure? In fact, when we looked at one of the ECG, which is one of the tools that we use to decide if a patient's ischemic or not, in fact, the presence of ST segment depression was an important predictor of 30-day mortality, even after accounting for the emerge predictors. And so we've taken the approach of kind of trying to predict outcomes in two dimensions. Here, both the 7-day mortality risk score and the 30-day risk score, where using these variables that you input mathematically, it will provide an estimate of the risk of whether the patient is low risk at both 7 days and 30 days, or high risk at other time points, or intermediate risk, and based on that, make recommendations about whether the patient could potentially be admitted to hospital or be discharged home. We find that the area of ischemia is quite important, and this slide shows you that patients who have an ischemic etiology are actually more likely to be rehospitalized. In fact, a mildly elevated troponin here, in patients who have a mild elevation of troponin, not necessarily indicative of myocardial infarction, have a 13-fold risk of being readmitted at 30 days for ischemic heart disease. So it seems to be, evidence of ischemia seems to be a really important marker of both mortality risk and readmission. So, in the earlier talk, we heard about the difference between observational studies, a lot of the data shown here are observational, and pragmatic clinical trials. And I also agree that we are heading into an era where doing pragmatic clinical trials is quite important. And so, we're taking the approach of testing the hypothesis that using risk stratification in the emergency department, and then combining that with good, excellent standardized outpatient care can improve outcomes. This is in the COACH trial, which is a comparison of outcomes and access to care for heart failure trial. We'll be looking at trying to determine if a strategy where we risk stratify and identifying whether a patient is high risk and perhaps requiring, likely requiring admission, versus being lower risk and likely perhaps being able to be discharged directly or being admitted for a short hospital stay, can combine with rapid heart failure care, where care really comes to, where a lot of the diagnostic testing and investigations done in the hospital are done in an ambulatory setting, could result in better decision making and improved outcomes. So in conclusion, heart failure readmissions have implications on the healthcare and the patient. The emergency department is a focal point, and really I would submit a final decision point before readmission occurs. The very interesting area of the whole ischemia and interaction with ischemia and heart failure, and how it seems to be a pretty important signal for predicting bad outcomes, both mortality and readmission. And we are hypothesized that by better identifying the patient's risk and standardizing and providing rapid, high-quality ambulatory care, that we could improve safety and efficiency of care. Thank you very much.
Thanks very much, Doug. An excellent and thought-provoking talk. We have time for one question. First hand up wins. I think John got you just by a half a second, Adrian. Get him back, yeah.
Doug, with respect to the Ontario variation, you showed us data earlier indicating that outcome depended upon whether a patient saw a physician or no physician or a specialist or both. With respect to the variation in Ontario concerning admissions and mortalities at 7 days or 30 days, do you have data regarding differences between teaching and non-teaching hospitals and whether patients were seen only by an emergency physician or by a medical resident or a cardiology resident, and whether the level of expertise involved in making that decision had an impact on outcome decision to admit, discharge, and mortality?
Yeah, so that's an excellent question, and we haven't delved into that issue in great detail. What we've seen is that, because in these types of studies we're looking at patients who walk in through the emergency department, and in those, when you take all comers who walk into the emerge, not necessarily being transferred in from another hospital, patients look actually fairly similar. Now, there's a wide range of what's considered a teaching hospital, what the province considers a teaching hospital, and so not all hospitals are necessarily downtown core, quaternary care hospitals, and so that may be some of the reason why. What we do notice, though, is that, and this is some of the work that we're looking at now, is that when you look at the patients, including those who are, who might need more acute care, the teaching hospitals tend, to be sicker. There's a lot of kind of interesting variations based on the type of hospital that we're trying to dig down. One of them, for example, is intensive care unit, and the type of patient that gets into an ICU, that gets admitted to an ICU at a teaching hospital versus a non-teaching hospital, very different, and much sicker in a teaching hospital, as you might imagine.